Welcome to This Explainer. Today, we're stepping into the shoes of a medical detective. We are going to explore the absolutely fascinating, highly structured world of the comprehensive psychiatric assessment.
So let's dive right into this with a pretty fundamental question. How exactly do you diagnose an illness you can't even see on an MRI or an X-ray? I mean, think about it. If you have a broken bone, boom, the evidence is right there in black and white. But psychiatric illnesses, they require a completely unique kind of medical detective work. The clues are invisible. They're hiding right there in plain sight within a patient's words, their physical movements, and their personal history. Basically, we have to map the mind.
To do that, here's our roadmap for today. We'll start by going beyond the standard checkup, explore the art of history-taking, break down the mental status exam, decode thoughts and speech, factor in physical and risk elements, and finally, put the whole thing together.
All right, Section 1, Beyond Checkups, Evaluating the Mind.
Now, while your standard medical exams look directly at the physical body, psychiatric exams assess the mind through a really highly structured clinical conversation. And that conversation always begins with what's called the chief complaint. In a psychiatric assessment, the doctor absolutely must record this exactly as the patient states it. We're talking in quotation marks no matter how bizarre it might sound to you or me. We do not paraphrase. Why? Well, because if a patient comes in and says, "The space aliens are attacking outside my garage, so I came in for help," the detective can immediately start testing hypotheses that involve psychosis, and then conduct the rest of the interview based on that specific clue. Moving right along to Section 2, the art of history and testing those hypotheses. Okay, so this interview isn't just some casual chat. It's actually a rigorous protocol for gathering information to establish a timeline and test clinical hypotheses. The process follows a very logical, chronological progression. Step 1 is open questions. You let the patient speak freely to truly understand their subjective experience. Step 2 moves into directive or closed questions. This is where the clinician starts pinpointing specific clues to test their working theories. And finally, Step 3, fully clarifying the symptoms.
You know, there's actually a really elegant difference between these question types. Think about physical pain for a second. A doctor might ask an open question to just hear about your experience, but then they'll pivot to closed questions to ask exactly how the pain varies when you exercise or eat certain foods. Well, the exact same principle applies to psychiatric symptoms. We use closed questions to explore how a patient's symptoms relate to their daily activities and their environment.
But hey, symptoms don't just exist in a vacuum, right? We have to gather critical background clues in the social history. We're talking everything from early childhood and occupational history to relationship dynamics and drug or alcohol use. We are actively looking for the patient's baseline functioning, any potential stressors, or traumatic events. Fundamentally, we're trying to answer one major question. Why is the patient presenting right now?
Which brings us to Section 3, the mental status exam, focusing on the current state.
Think of it this way. If taking a history is like reviewing old case files, the mental status exam, or MSE, is the active crime scene. It's the psychiatric equivalent of the physical exam. It assesses the patient's mental state right at the exact time they are being seen. So it's not a history, it's an examination of their current state. A skilled clinician will take their subliminal perceptions of a patient's behavior and bring them right up to the surface, turning them into clinically meaningful descriptions across areas like appearance, speech, mood, and perception.
And honestly, physical observations alone can be massive clues. Impaired self-care or physical slowness, that might signal severe depression. Sustained, rigid posturing could indicate catatonia, which is a condition we often see in psychotic disorders. Or the doctor might notice extreme motor restlessness, where the patient literally cannot sit still, known as akathisia, or even tics and dyskinesias. These physical signs can immediately signal underlying conditions, or even highlight really severe side effects from antipsychotic medications that require urgent, right-now intervention.
Okay, here's a crucial distinction that trips a lot of people up: affect versus mood. Think of mood as the long-term emotional makeup, the climate. Affect? That's the immediate emotional manifestation, today's weather. A vital piece of diagnostic data is an incongruous affect. For instance, if a patient is smiling brightly while describing the tragic death of a loved one, well, that mismatch is a major red flag for the clinical detective.
All right, Section 4, Thoughts and Speech, Decoding the Mind.
As the conversation flows, abnormalities in the brain often show up in how a person talks. We listen very closely to the form of thought. Like, is their speech incredibly slow, pointing maybe to severe depression or an organic brain syndrome? Or is there a flight of ideas, where they have this rapid, pressured speech skipping wildly from thought to thought, heavily suggesting mania? We even listen for what we call neologisms. These are completely invented words with absolutely no recognized meaning, or they might be condensations of existing words. Using neologisms strongly hints at conditions like schizophrenia or structural brain disease. We might also catch echolalia, which is the automatic parrot-like repetition of a phrase the examiner just said.
Next up, we evaluate the content of those thoughts, particularly looking for delusions. Now, delusions can be primary or secondary. Secondary delusions pop up to explain another hallucination, like, say, believing a radio transmitter was planted in your head because you're hearing voices. But primary delusions? Those arise completely de novo, out of nowhere. For example, a patient sees a totally normal red traffic light and immediately, with absolute 100% certainty, interprets it as a sign that they are a divine figure.
Let me ground this complex psychopathology with a really brilliant clinical example from our sources. A delusion is actually defined by the faulty reasoning used to support the belief, not necessarily whether the event itself is factually impossible. So the belief that your wife is unfaithful specifically because the kitchen kettle made a funny noise when boiling water, that is a delusion. Even if an affair was actually occurring in reality, the belief remains delusional because the evidence and the reasoning used to reach that conclusion are completely pathological.
On to Section 5, Physical and Risk. Ruling out the organic. Here is a massive twist in our detective story. Sometimes an illness of the mind actually originates from an illness of the body. A comprehensive psychiatric assessment absolutely must rule out the organic first. We use physical evaluations, neurological checks, cognitive testing like the MoCA, and even neuroimaging. We have to check for medical contributors, things like thyroid issues, structural brain diseases, or frontal lobe dementias that might just be masquerading as psychiatric disorders.
And right alongside the physical, we must urgently integrate risk assessment into that very first clinical hour. We're evaluating for suicidality, violence, and any neurological red flags. And listen, we need to squash a huge misconception right now. Asking a patient about suicidal thoughts does not lead to an increased risk of suicide. It just doesn't. In fact, fully exploring specific plans, protective factors, and what exacerbates their symptoms is completely essential for creating a safety plan and ultimately protecting the patient's life.
Finally, Section 6, Putting it together. The working diagnosis.
So our investigation comes full circle. We combine all these distinct verbal, physical, and historical clues into one cohesive working diagnosis. But beyond all those objective signs, here is a truly fascinating and often totally overlooked piece of data: the examiner's own gut reaction. The physician's emotional response to the patient actually serves as a subtle diagnostic tool. If the examiner feels a sudden sense of distress, they might be picking up on a patient's masked depression. Feeling completely off balance and out of touch with the conversation, that can be an early indicator of schizophrenia. Even feeling frustration can be a clue that they're dealing with a help-rejecting complainer.
But listen, for all the clinical signs, the timelines, and the risk assessments, we can never forget the absolute core of this whole scientific detective work: empathy and active listening. At the center of this highly structured medical investigation is a vulnerable human being in distress. Non-judgmental communication, really active listening, and building a therapeutic rapport aren't just polite bedside manner, right? They are literally the critical instruments required to gather the data accurately in the first place. We've seen how tracking speech patterns, observing subtle motor movements, and testing out hypotheses can reveal the unseen illnesses of the human brain. But it leaves us with a pretty powerful final thought. As we map the mechanics of the mind with ever greater precision, how much more might we discover when we truly learn to listen? Thanks so much for joining me on this explainer, and keep staying curious.